Hey everybody, I hope that you're having a good week. It's kind of nice and damp around here. I hope that you realize by now that actually the content in your theory and your practicum has settled down a little bit since we've gotten those head to toes out of the way and stuff. So we're going to finish up this last one on fluid and electrolytes for you. We're going to be doing the adult portion now. The first part of your chapter, and yes, you only have one chapter in the book on this, and then that piece of a chapter in your pediatric. But the one chapter also goes through part of the pathophysiology and the anatomy and physiology of fluids, okay? So I'm going to hit on it a little bit, but I'm not going to concentrate a whole lot on that part. All right, filtration influences. One example of this would be blood pressure. You know, your hydrostatic pressure, you have to form equilibrium so that the fluids on both sides of the vessel are at the same level. Otherwise, you are going to have a filtration through. Gradients is the difference in disequilibrium are noted when one space has a higher hydrostatic pressure than the other. And when a gradient exists, fluids are going to filter until each side has that same equilibrium again. And this is your filtration influences on your fluid and electrolyte. Okay, what are the clinical significance? Filtration is responsible for capillary membranes, or is produced by capillary membranes. They only have one layer of thickness between that capillary space and the interstitial space. Therefore, it's a lot easier for things to be filtered out, such as your waste products, and for your electrolytes to be filtered back in. Okay, they are very porous. Elevated pressure on the capillary side is going to make the fluids filter out into the interstitial space, and this is going to result in your edema, which also you will see in your third spacing patients. Okay, now let's talk about diffusion's influence. The particles are like jumping beans. This is the best way I can give it to you that I understood it the most. The particles are like jumping beans. They jump around until they finally hit a spot in the membrane that is large enough for them to finally fit through. And this, it makes sense to me when you think about it as jumping beans, because the more beans you have, the more likely they are to hit that space and to be able to pass through. Your book gives you another one on diffusion, another example on diffusion, which is a very good example. And it's a ball rolling downhill. You know, the steeper the hill is, the faster that ball is going to roll. So, whichever way you want to look at it, the particles are in motion. According to the abundance, they hit off of each other and they're bouncing around in the fluid in there. And once those particles collide with the membrane, like I said, eventually they're going to hit a spot that is weak enough or has a big enough space between the cells that it can pass through. Okay, the speed of diffusion is going to depend on the concentration gradient that is in the fluids. Okay, the more particles you have, the faster stuff will diffuse. Why is that? Because there's more of them there to get the chance to diffuse. Okay. The larger the difference in numbers of particles on each side, the faster your diffusion is going to happen. Your body, no matter what, tries to hit an equilibrium. So if you have more sodium inside the body and less sodium, or outside the cell, inside the cell, and less sodium outside the cell, that sodium is going to bounce off the walls of that cell until they finally pass through into an area of lower concentration where they belong, so they can help the body with equilibrium. Okay, diffusion is going to last longer or it's going to take longer, and there's a difference. There's a difference in the speed according to the particles that are present. Okay, diffusion will last as long as there's a difference between the two sides of fluid. Okay, between the two sides of the membrane as far as fluid goes. Okay, clinical significance of diffusion. Let's see here what we got. There's 10 times more sodium outside the cell than inside the cell. Think of sodium as a boat. Here's you another one of those stupid little illustrations of mine. I apologize. Okay, the boat is trying to go upriver. It's trying to move into the cell against the flow of the fluid. Okay, it needs a motor to help with this. Which we're going to consider the special sodium pump that's going to help move that extra sodium present inside the cells, or upstream, whichever way you want to look at it. So you say sodium is your boat. Your boat needs a motor to help it move from one area to another area. And what is that motor going to be? Well, there are several different things that can cause that motor to run, okay? It's kind of like a lock and a key situation. Excuse me. The glucose in a diabetic, like the lock and the key, the same is with the electrolytes. So if you've got a patient that is low on sodium and your door, the sodium doesn't have the key to fit in the door, then you can bring something along the key that will open that doorway and allow the sodium to pass through. That's how insulin works. It is the key to diabetes. Okay, your blood sugar is trying to pass through the door or the cell wall, and it can't get there, so the insulin comes in, and it is the key that can be inserted into the lock and open the door so the sugar could go through. Alright, and one of those pumps that helps in this with your sodium is your sodium potassium pump. Okay, moves one particle from an area of lower concentration into an area of higher concentration, and that's just going upstream from what is normal, is what I'm trying to get at. Now let's look at osmosis. Okay, in osmosis you're going to have a semi-permeable membrane, with one side having that higher concentration than the other. The fluids are going to go from the lower particle concentration to the higher, okay, in order of dilute it down to have equal parts of both on each side of the membrane. Okay, so they act together with filtration on the capillary membrane. So your osmolarity in the normal blood is 270 to 300 millimoles per liter, and that is the same as your isotonic solutions, which are normal saline and lactated ringers. And then if you have a hypertonic solution, the milliosmoles are going to be greater than 300. Okay, and that would be like your salines of like 3% and 5%. And then your hypotonic are going to be fluids that have less than 300 milliosmoles per liter, such as your half normal saline. Alright, now make sure that you are well aware of which category each fluid falls into for this test, and also for clinical purposes when you're taking care of your patients. Now, article I have given you right along with this has a very good chart on it, on the different types of fluids, what the influence is on of the fluids, and what you need to monitor for. Okay, so and now let's look at the clinical significance of osmosis. It activates the thirst mechanism. It happens when the cells shrink as water moves out of the cells into a hypertonic extracellular fluid. Drinking is going to dilute the extracellular fluid osmolarity, and it restores the water balance. Also, osmosis helps with the premature born that have a higher composition of fluid and must be monitored very closely. As the patients age, also osmosis can be affected by the fluid compositions that are decreased in the older adults. Their thirst receptors are less sensitive with age, and so they might not want to drink as much. The feeling of thirst can cause osmosis to be activated in the brain cells. The osmoreceptors are going to respond to changes in the extracellular fluid osmolarity. Inactivation of the thirst response from a loss of body water. But when you have that loss of body water, the particles are still left, so the extracellular fluid volume is decreased, but your osmolarity is increased because you still have the particles of sodium and potassium and all of your electrolytes within it, okay? So, fluids found in each type. Let's talk about those. Like I was telling you just a minute ago, isotonics are your 9% normal saline and your lactated ringers. Hypotonics, your D5W, your 0.25% normal saline, and your 0.45% normal saline. Okay? And your hypertonics are going to be your D5.5, your D5 normal saline, your 3% normal saline, and your 5% normal saline. Okay? Now, let's talk about electrolytes norms, okay? These norms are taken straight out of your med-surg book. You need to have these memorized. All right, you will see them on this test and on almost every other test that you're going to have in some form or fashion. You must know these values, and they are in your med-surg book on page 152. But like I said, I have almost all of the charts that you need to memorize on these PowerPoints for you. So maybe it would be a little more helpful for you. Excuse me. Okay. Influences on fluid balances. As you can see here, older adults have a decreased ability of their osmoreceptors to trigger that thirst mechanism. It can increase their risk for dehydration. Also, their gender, an obese person, especially females, which tend to have a little more body fat than males, and I kind of take exception to that sometimes, but that's just me. An obese person has less total body water than a lean person because the fat cells contain almost no water. Women of any age have less total body water than men of similar sizes and ages, just because our muscle mass is smaller. Men tend to have more lean mass than women, and women have more body fat, okay? The difference in water distribution may be responsible also for the differences that you see in men and women on their response to different drug and medications, okay? So you need to keep that in mind too. With fluid loss, the kidneys are the most important and sensitive form or regulator or regulation and adjustment of fluid volume, okay? The minimum amount of urine per day to remove toxic waste is 400 to 600 milliliters per day. Anything below that, the waste are going to be retained, and this can cause a lethal imbalance. It can cause acidosis and toxic buildup of nitrogen in the body. Okay? Insensible water losses increase with thyroid crisis, traumas, burns, extreme stress, like we put you under, and fever. These patients can also include ventilator patients that have insensible water fluid losses, tachypneic patients, or patients with continuous GI suctioning and excessive sweating. And all of these can cause an increase of fluid losses from this 500 to 1,000 a day to maybe up to 2 liters, okay? So now let's talk about some hormone influences are involved in the regulation of our fluid balance, okay? The kidney nephrons are stimulated to reabsorb sodium and water. Aldosterone also acts to prevent potassium levels in the blood from becoming too high. Aldosterone is known as the water and sodium saving hormone, okay? So remember that. Aldosterone saves water and it saves sodium. ADH indirectly regulates electrolyte retention or excretion. It acts on the kidney tubules and collecting ducts, making them more permeable to water, only pulling it back into the blood, which decreases your blood osmolarity because of dilution. All right. With this dilution, the cells swell, inhibiting the ADH release. And then you're going to have effects of the natriuretic peptides. They're opposite the effects of aldosterone, so reabsorption is inhibited. Your glomerular filtration rate is increased, causing an increase in your urine and decreasing your circulating blood volume and osmolarity. Okay? Now let's see. Let's move on to our fluid balance and look at the renin-angiotensin 2 pathway triggers. Here are some of the triggers for you on your pathway. You have a chart on page 154 that you need to know. I have not put that on here, but I will talk you through it. These are the triggers that you're going to see to triggering the renin-angiotensin: low blood pressure, low blood volume like in dehydration or hemorrhage, your low blood sodium, and then your low blood oxygen. Okay? It's triggered by a decrease in tissue perfusion to stimulates the kidneys to release the renin from the tubules. The renin activates angiotenogen, which is a blood protein, and that will activate angiotensin 1. Angiotensin 1 is out there floating around, but it is too weak to really produce any appropriate action potential without angiotensin converting enzyme, which helps it convert from angiotensin 1 to angiotensin 2. Angiotensin 2 then causes the vasoconstriction, which increases your resistance in your blood vessels by decreasing the size of the blood vessels. Okay, so it vasoconstricts them. When the afferent arterioles of the kidneys are constricted, the glomerular filtration is decreased, which causes a decrease in your urine formation, and sodium and water are reabsorbed, which increases your blood volume to improve that tissue perfusion. Okay? A slower process is also in the renin-angiotensin, and that is where angiotensin 2 stimulates your aldosterone secretion, which increases the kidney's reabsorption and increases your blood volume. And both of these, or all of these pathways, or all of these actions will work together to help maintain that tissue perfusion. Okay? What is the significance of this? Angiotensin 2 pathway It's stimulated when the patient is in shock or has a stress response. ACE inhibitors disrupt the renin-angiotensin 2 pathway by blocking or reducing that angiotensin converting enzyme. That's going to reduce the amount of angiotensin 2 that's going to be present in the body. Diuretics increases your excretion of sodium, so less is present, therefore the blood pressure is going to drop. Angiotensin receptor blockers bind with the receptor sites so that the body cannot respond to the angiotensin and blood pressure is lowered, okay? So these are some of the clinical significance that you need to think about when you're dealing with someone with fluid and electrolyte imbalances, okay? Now, there are two forms of imbalances, right? Dehydration and fluid overload. Dehydration is your most common, and most commonly it is isotonic, where you have a decrease in both the extracellular fluid and the intercellular fluid, or the decreases in the extracellular fluid and the intercellular fluid can be normal, okay? And the other one would be your fluid overload, where your fluid intake or retention is greater than what your body needs. If you'll notice, I said both of these were conditions. They are conditions. They are not diseases. Dehydration can be either actual or a relative loss of total body water. An actual is a decrease in the total body water by too little intake or too great a loss, okay? The relative is when the water shifts from the plasma to the interstitial spaces. And that's going to be important that you understand the difference between an actual and a relative, okay? In isotonic dehydration, there is no shift of fluid between the spaces. The circulating blood volume is decreased and it leads to inadequate tissue perfusion. The fluid is lost from the extracellular space only. The intercellular space is normal usually. Okay? The elderly are at high risk for dehydration because they have less total body water. Most of them also have a decreased thirst sensation and might have difficulty obtaining or drinking their fluids. They are also the patient that you see most often taking those diuretics and antihypertensives and laxatives that can affect the fluid balance in the patient, okay? Okay, when a patient is in fluid overload, and when that fluid overload is severe or happens in a person with cardiac or kidney problems, it can lead to heart failure and pulmonary edema. It leads to dilution of the sodium and the potassium, and the dilution of those two electrolytes can lead to seizures, coma, and even death if you're not careful with your patients, okay? Now, here are some of the causes of dehydration. Like I said, you need to know the difference between an actual and a relative. So let's see if you can figure these out by marking them with an A or an R, all right? And I'm going to give you just a couple of seconds to go through here and look these over and see if you can determine if they're actual or if they're relative losses, okay? Such as hemorrhage, profuse salivation, profuse diaphoresis, long-term MPO status, hyperventilation, impaired thirst, impaired motor function, vomiting, fistulas, burns, diuretic therapy, diabetes insipidus, unconsciousness, diarrhea, ileostomy, severe wounds, GI suction, difficulty swallowing, and fever. Can you determine which ones are which? Okay, we're going to move on. Signs and symptoms of dehydration to assess. You're going to need to look at the patient's history, okay? Because 1 liter of water weighs about 2.2 pounds. Monitoring their daily weight is the best indicator of any fluid loss or gain that the patient might have. If a weight change of 1 pound corresponds, with 500 milliliters of fluid loss. Okay, so you need to remember 1 pound corresponds with 500 milliliters. Okay, all of the lab work is pointing to hemo concentration which is not seen in patients with dehydration. Um, it can be caused by hemorrhage because the blood loss and the plasma fluid loss happen together. Okay, so you will see that they might look like they're hemoconcentrate, but they're not. Okay, a quick way to assess fluid retention or deficit is to ask if they've had any changes in fitting of their rings or of their shoes, things like that. Your patient that has dehydration is at greater risk for falling due to orthostatic blood pressure changes and decreased tissue perfusion. Okay, when they have this decreased tissue perfusion, what you could see in their neck veins is that they will have a flatness in those neck veins, and they're in their hand veins. So just by a quick glance, you can kind of tell if you've got somebody that's on the verge of dehydration. Okay, so pay close attention to those type of things. The respiratory rate increases as a compensatory mechanism to maintain oxygen delivery to the patient. With decreased tissue perfusion, the skin turgor needs to be checked on that chest or the forehead, especially in your elderly patients, because of decreased elasticity in their arms and their hands, which comes with age. Okay. Let's see here. Your turgor should be less than 3 seconds in a well-hydrated patient, so you'll need to check their turgor. Oral mucosa, if they are dehydrated, is going to be dry and sticky. There won't be any moisture to it. They might have a thick, sticky coating on their tongue. They'll have cracks. They can have fissures on their tongue, their lips, their tongue can even have what they call deep furrows on it from being so dehydrated. Remember to distinguish dehydration of a patient, a true dehydration, from a dry mouth side effect that medications can cause. So you need to explore their medication list with them as well. You need to monitor their mental status and temperature, because a decrease in the blood flow to the brain can cause a decrease in their mental awareness. They can show some confusion. They can also demonstrate a low-grade temperature. Okay? Dehydration can produce that low-grade temperature. A patient with a temperature that's elevated above 102 for longer than 6 hours can experience dehydration. And here's another point that you need to remember. Okay, 1 degree of Celsius temperature rise is equivalent to 500 milliliters of a body fluid loss. Okay, kidney output can be seen to be below 500 milliliters a day for a patient without kidney disease, and this can be cause for concern, okay, if it's under 500 milliliters per day. Or if they have weight loss over a half a pound per day, it is considered a fluid loss. Now, weight loss of that first half a pound is considered to be due to metabolism, okay? But anything above a half a pound, you need to be alerted to. Okay, dehydration is determined by signs and symptoms along with their lab results. So you need to know your norms on all of your labs. Usually the patient's going to demonstrate hemoconcentration unless the dehydration is caused by a hemorrhage, which is a loss of blood or plasma products together. Okay, So, and this slide shows you a little bit about your signs and symptoms on the lab results. You should have an elevated H&H for somebody that's dehydrated. You'll see serum osmolarity will be elevated. Their glucose, protein, their buns, and their electrolytes will all be altered. And they're going to have a specific gravity that is greater than 1.030, okay? So what are we going to do for these patients? Interventions, number 1 is patient safety, number 2 is fluid replacement, and number 3 is drug therapy. However, the most important thing for you to do is to assess the problem, find the reason, and fix it, okay? The patient is at increased risk for fall due to orthostatic hypotension. They also have dysrhythmias, they can have muscle weakness, and possible confusion right along with this dehydration, okay? You need to assess their gait, their muscle strength, and their level of awareness. Mild to moderate can be usually corrected with oral fluids if the patient is alert enough to swallow and can tolerate those fluids. Those fluids need to be divided across the nursing shift so one shift is not overloaded over another, okay? You need to make sure that they are physically able to swallow and to obtain their fluids that they need. The staff needs to be offering, and you need to instruct your CNAs to have offer these patients fluids every time they check on them, and offer at least 2 to 4 ounces every hour. And for a patient that is severely dehydrated, you're going to see a low-grade temp with them, okay? Drug therapy usually focuses towards restoring fluids and controlling the cause. Fluid replacement should be calculated based on that patient's weight and clinical manifestations. All right, the rate of replacement is going to depend on the degree of dehydration that the patient has, the blood osmolarity, the cardiac and pulmonary and kidney status of this patient. So it's important to monitor the pulse rate and the quality of the urine output on these patients very closely. Some drugs that you can see might be used with these patients are going to be things that's going to stop fluid loss, right? Like your antidiarrheals, your antimicrobials, antiemetics, and your antipyretics, okay? Like I said, you need to know the chart on page 157. And let me just flip over there right fast. It gives you a chart on best practices for the patient's safety and quality care. In other words, it is a QSIN box. And anytime you see QSIN in your book, please know that Miss Smedley is very interested in those, okay? So it might benefit you to look at those some. Okay. Fluid overload. They can be caused by an excessive fluid intake, inadequate excretion of fluids, or a dilution of your electrolytes. Overload is also not a disease, just like your dehydration. It is a clinical indicator of a problem in fluid intake or retention greater than the body's fluid needs actually are. When the patient has a disease process of the cardiac or the kidney function, it can lead to heart failure and pulmonary edema when they're in fluid overload. The dilution of sodium and potassium can lead to seizures, coma, and to even death in these patients as well, okay? Okay, so what are some of the causes of fluid overload? You can see excessive fluid replacement. In other words, you're giving them fluid way too fast, okay? Or they're drinking too much. Heart failure, syndrome of inappropriate SIADH, or syndrome of inappropriate ADH, okay? Water intoxication, where they just drink. How about kidney failure in the last phases of kidney failure? And then long-term corticosteroid therapy can cause fluid overload. and also psychiatric disorders like polydipsia. Okay? Now, on these, again, take a couple of minutes and mark them with A for actual or an R for relative to make sure that you're understanding the difference between the two. Okay? So, now let's go on to signs and symptoms. And what are you going to assess for? Okay, the labs, you're going to want to make sure the electrolytes, they can be normal. You can see a decreased H&H, decreased serum protein levels on these patients. The cardiac, think about this, overload. Everything is full of fluid, okay? So you're going to have an elevated bounding pulse. Their blood pressure is going to be up. Their central venous pressure is going to be up. They're going to have distended neck veins, engorged varicose veins, and their weight's going to be up, right? Respiratory is they're going to have shallow respirations. They're going to have shortness of breath. They're going to have crackles. Their skin, they're going to have pitting edema. Their skin's going to look pale, and it's going to be smooth looking, okay, because it is stretched out, right? Your neuro, you're going to see altered level of consciousness, headaches. Think about this as an enclosed chamber. You're putting more fluid in there, so it's going to cause everything to go haywire. They're going to have that altered level of consciousness. They're going to complain of headaches because there's not any space up there, right? They're going to have visual disturbances because they're pushing on the optic nerves. They're going to have muscle weakness because their brain is just not going to be able to work right. Okay, and they will feel paresthesias. All right. In the GI, think about it. Like I said, more fluid, so you're going to have increased motility, and they're going to have an enlarged liver, right? Okay. The diagnosis of overload is based on your assessment and your laboratory test results, just the same as the dehydration. Now, what are we going to do as far as interventions go? Patient safety is number one, of course. Actually, number one is find out the cause and fix it, right? The best way to help anybody with any of these situations is to fix it as fast as possible. And then, as a nurse in your QSIN, you're going to be really cognizant of your patient safety. You're going to also have drug therapy interventions, nutritional therapy interventions, what you're going to monitor, and your fluid restrictions, okay? Now let's talk about patient safety. That patient is at risk for skin breakdown, right? So you're going to make sure that they have pressure relieving devices on their beds. They might have overlay mattress. You're going to monitor that skin on a daily basis, especially over the bony prominences. If they are having difficulty with the respiratory system because of fluid overload, they're more than likely going to be on oxygen, so you're going to have to be sure that you monitor the skin around that oxygen tubing, okay? Monitor the patient that's on drug therapy for weight loss and increased output. What can I say? For electrolyte imbalances, you're especially going to have to monitor their ECG. Make sure that you look at the labs, especially the sodium and the potassium, at least every 8 hours on these patients. Okay, they need to be monitored closely. The patient will more than likely be put on a no added salt diet if their fluid retention is mild. If it is more severe, they can be limited to 2 to 4 grams of sodium a day in their diet. So you're going to need to teach this patient and the family how to record and how to read food labels to ensure that they are following their sodium restrictions. Now this is one of the, I guess, right up there with diabetes, is one of the least favorite diets one of the hardest diets for a patient to comply with, basically because most people like their salt, just like their sugar. Most people like their sugar, okay? You need to monitor the fluid intake. This can be done by watching the specific gravity of their urine. Like I said, specific gravity of 1.005 can be indicative of a fluid overload. So the lower the number it gets, the more dilute the urine is. Is that correct? Okay. Fluid retention may not be visible unless you weigh them. And a weight gain is a very excellent indicator that these patients have got fluid retention. Like I said earlier, a weight gain of over a half a pound a day is indicative of fluid retention, okay? Metabolism only accounts for that half a pound, which is approximately 500 milliliters of fluid, okay? Now, if you're at the hospital and you're weighing a patient in the bed, you need to make sure that you or your CNA or whoever's doing the weighing, make sure that they remove all of the tubes that they possibly can from the bed and the equipment off the bed, and keep the same amount of pillows and bed covering on that bed every day when they are weighing that patient, okay? Because even though you might think it's something that's lightweight and it's not going to add much, it adds enough to be very significant on your patient, okay? You want to teach that patient on discharge how to weigh themselves and when they need to report. They need to tell their healthcare provider if they have more than a 3-pound gain in a week or more than 2 pounds in a 24-hour period. They need to be reporting that to their doctor, okay? Now, electrolyte balances and imbalances is our next section to go to. The difference in concentration from your extracellular fluid to your intercellular fluid helps to maintain the membrane excitability and enables the nerve impulses to be transmitted. Older adults and patients with kidney and endocrine disorders and those taking fluid altering drugs are the greatest risk for fluid and electrolyte imbalances in your patients, okay? And we're going to break this down one by one. So you can see it's going to take a little while for us to get through this. Okay, for sodium. What is sodium used for? It is vital for your skeletal muscle contractions, for cardiac contractions, nerve impulse transmissions, and your sodium level and movement influences your water balance, okay? Extracellular sodium levels determine whether water is retained, excreted, or moved from one fluid space to another. It's regulated by your kidneys with the influence of aldosterone, ADH, and your NPs, like we talked about earlier. Low sodium levels inhibit the secretion of ADH and NP, and it triggers your aldosterone secretion. So high sodium levels inhibit aldosterone secretion and directly stimulate secretion of ADH and your natremic peptides, okay? Some of the causes for hyponatremia, which is a level below 136, okay? Now here you go again. I've given you a list. You need to take some time later on and put an A or an R beside the ones, A for actual and an R for relative, okay? So you can make sure that you understand the differences in these. Hyponatremia is a level below 136 milliequivalents per liter, which causes two changes. It reduces the excitable membrane depolarization and cellular swelling, okay? The depolarization is slower so that excitable membranes are less excitable. Does that make sense? The osmolarity of the extracellular fluid is lower than the intracellular fluid, and that causes the water to move into the cells, causing them to swell up. The larger the cell gets, the more likely it is to lyse and die. A common cause of hyponatremia is a prolonged use or overuse of diuretics, especially in your older adults, okay? So like I said, mark those with an A or an R to see if you understand the difference between an actual and a relative. Okay? Now, signs and symptoms of hyponatremia. To assess for, you're going to look at their cerebral, their neuromuscular, their GI, and their cardiovascular, right? You're going to see cerebral edema, which is causes behavioral changes. Because of that edema, there's an increase in your intracranial pressure. You need to watch their behavior. You need to watch their level of consciousness and their mental status. A sudden onset of an acute confusion or increased confusion can be seen in your older patients. If the level continues to lower, the patient can have seizures, coma, and even die, okay? They will experience generalized muscle weakness. You need to assess them for a decrease in their deep tendon reflexes and muscle weakness in their legs and their arms. The muscle weakness is noted. If muscle weakness is noted, you need to assess the respiratory status in these patients, because the diaphragm can also be affected, which can affect your respiratory status. You will have increased motility in the GI, which is going to cause some nausea, abdominal cramping, hyperactive bowel sounds, and these patients will probably have some frequent watery diarrhea. Hyponatremia with hypovolemia will lead to weak pulses due to a decrease in your blood volume. Hypotension, dizziness, and central pressure is going to be low on these patients as well. Hyponatremia with hypervolemia, in other words, too little salt, too much water, is going to present with just the opposite. You're going to see bounding pulses. You're going to see normal blood pressure to high blood pressure. Okay? You're going to see decreased GI motility. All right? So let's see, what type of interventions are you going to do for these patients? Well, you've got drug therapies, nutritional therapies, patient safety, skin protection, and patient teaching that you need to focus on. The priority of nursing care is going to be to monitoring the patient's response to therapy and preventing hypernatremia and fluid overload. Okay? IV infusions are delivered using the pump controller to prevent any accidental increase in the infusion rate. You need to monitor the infusion rate and the patient's response to fluids. Drug therapies for hyponatremia caused by inappropriate ADH may include lithium and decellamycin. Okay? These patients are going to need to be assessed hourly for excessive fluid deficit, potassium loss, and also for increased sodium levels. These patients may need to be on fluid restrictions long term. When fluid overload is the cause of their hyponatremia and kidney excretion is impaired. Okay, so you're going to need to protect that skin, that overlay again on the bed. You need to monitor for orthostatic changes in ambulation. Okay, and you need to teach the patient how to increase their oral salt intake and restrict fluids. Okay, to help the salt catch up. All right, now let's talk about the reverse, hypernatremia. Here's your causes for hypernatremia, and go ahead and put you an A and an R beside those and determine which way they are going to be. Okay, is it an actual or is it a relative? Okay, signs and symptoms of hypernatremia to assess for. You're going to assess the neurosystem for mental status changes. This is going to start with an altered cerebral function. You need to monitor their mental status with their attention span and their cognitive function. In a patient with hypernatremia, and normal or hypovolemia, they're going to have a shorter attention span and might be agitated or confused. If they have fluid overload with their hypernatremia, they are going to be lethargic and drowsy, stuporous, and even might be comatose. Excuse me. With mild accumulation, you're going to see muscle twitching and irregular muscle contractions. As these worsen, the nerves are going to get exhausted and the muscles are going to get progressively weaker. With severe or late stages of hypernatremia, you are going to have deep tendon reflexes that are reduced or absent completely. The muscle weakness is going to be bilateral with no specific pattern. You're going to watch the muscles for twitching. You need to assess strength and grip, and also assess their deep tendon reflexes. In the cardiovascular, you are going to see a decreased contractility because the high sodium concentration is blocking the calcium from entering the cells. Your pulse and your blood pressure can go any which way at all, either normal, high, or low. It's going to depend on your fluid volume and how rapidly the sodium goes up. The pulse increases with hypernatremia and hypernatremia, hypovolemia. In other words, too much salt, too little fluid. Okay? The pulses will be hard to palpate, and the blood pressure will also drop because of severe orthostatic hypotension and reduced pulse pressure. If the patient is too much fluid and too much sodium, in other words, hypernatremia, hypervolemia, they're going to have slow to bounding pulses. Their jugular vein is going to be distended, even when they're in an upright position, and their blood pressure is going to be elevated, especially the diastolic blood pressure. Okay? So what are we going to do for hypernatremia? Interventions are going to be drug therapy with normal saline or D5.5. You see diuretics, nutritional therapy, encouraging fluid intakes, sodium-restricted diets. Your patient safety is going to be another concern. Also, skin protection and patient teaching. Priority nursing care should focus on monitoring their response to the therapy, ensuring that they're safe, and preventing hypernatremia and dehydration, or hyponatremia and dehydration due to the therapy. In other words, you've pulled too much off, okay? The patient who has hypernatremia caused by poor kidney function will receive diuretics to help flush the sodium out. You're going to need to assess these patients hourly for symptoms of excessive loss of both sodium and potassium. Okay? The ones with mild sodium loss can be, for the patients that have a mild sodium loss, it can be prevented or corrected by ensuring that that their intake is sufficient and restricting their sodium intake, especially if the patient has kidney problems. Okay? Your nursing actions must focus also on ensuring that the patient's safety, especially with ambulation, their skin protection, and monitoring that lab work religiously. Okay? You need to teach the patient and the family how to monitor their weight and their I&Os, especially. Okay? Now let's talk about our potassium. Why does the body need potassium? It is critical for excitable tissue to depolarize and to generate an action potential. Mainly, it's controlled by the sodium-potassium pump within the membrane. 80% of potassium is removed by your kidneys. Aldosterone enhances kidney excretion. Okay? There's a large difference between the potassium in the extracellular fluid and the intercellular fluid. The intercellular fluid has a larger amount of potassium to it. The high level in the cells, with such a high level in cells, when the cells are damaged, they're going to release their potassium, which can cause your patient to be hyperkalemic. Most foods do contain potassium, and we consume more than enough in a well-balanced diet every day. The sodium-potassium pump moves your potassium in and your sodium out of the cells to maintain the balance that's needed. Okay? Hypokalemia is a level that is below 3.5 milliequivalents per liter. Here are some of the causes of hypokalemia. Again, stop and put an A by them or an R by them for either actual or relative. Okay? Hypokalemia can be a life-threatening event because every body system is affected by potassium. It can be either actual or a relative cause. In an actual cause, the depletion occurs when the potassium loss is excessive or when the potassium intake is not adequate enough. Okay? Your relative is going to occur when the total potassium levels are normal but the potassium distribution is abnormal. Or if they have a problem with the dilution by fluid overload. Okay? So mark each one of those as actual or relative. What are some signs and symptoms of hypokalemia to assess for? Okay, I've got them listed here, so let's see if we can get through this. Age affects the kidney concentration of urine, increasing your potassium loss. Okay. Drugs like diuretics and corticosteroids and beta agonist or antagonist can increase your potassium loss. Okay. So that's your age and your drugs. Then patients that take digoxin have an increased sensitivity of the heart muscle to the medication, which can lead to a toxicity of the digoxin in the patient. So you need to remember, if your patient is on digoxin, it is a medication that benefits you to pay close attention to the potassium level of the patient, because they can go toxic on digoxin because their potassium level is so low. Okay? Disease processes can lead to hypokalemia. You need to take a very good nutritional history on your patients and identify the ones that are at risk for hypokalemia. In the respiratory status, you need to assess the respiratory effort. Look at the nail bed color, mucous membranes, and the rate and depth of their respirations. Because they're hypokalemic, it's going to take a stronger stimulus to begin a muscle contraction. So severe hypokalemia can cause flaccid paralysis in your patient. Okay, so you need to check them for muscle weakness and hyporeflexia. The pulses are usually thready and weak, but the rate can be either slow or fast, either one. Okay. Dysrhythmia is heard and seen on your monitors on these patients. Because the heart is pumping ineffectively and the blood is not moving effectively, these patients can experience orthostatic hypotension. This puts your patient at risk at a greater risk for falls and accidents. I can't even talk this afternoon, I'm sorry. Altered mental status also puts them at a higher risk. It can lead to behavioral changes as well. In patients with hypokalemia, you can see changes like lethargy, to the point where the patient can not perform simple problem-solving tasks, like counting by threes, for instance. The GI In the GI, you know, your smooth muscle contraction is going to be decreased, so peristalsis is going to decrease, and this is going to lead to constipation. And if it's untreated or undertreated, this can lead to a paralytic ileus. Okay? You're also going to see, of course, your laboratory changes in your potassium level going down. But you will also see ECG changes, which will include a ST depression. You're going to have a flat or an inverted T wave, and you will have an increased U wave. Okay, so what are our interventions for hypokalemia? What are we going to do? Drug therapy, nutritional therapy, patient safety, bed rest, respiratory monitoring, and then your patient teaching. And I'm going to go into these a little bit, okay? Your priority interventions are ensuring adequate oxygenation, your patient safety, and prevention of injuries from not only the patient being up moving around, but also from your potassium therapy that you are giving them, okay? You need to closely monitor your patient's response to potassium therapy. You need to question the use of diuretics. Find out if their diuretics that they're using are potassium wasting, like the thiazides and the loop diuretics, and they need to be stopped in these patients. Okay? Administer oral potassium that is well diluted with their meals or just after they eat to help prevent nausea and vomiting. Potassium is severely irritating and should never be given IM or sub-Q. Potassium is also necrotic and can cause loss of function for the patient. If the patient has phlebitis or infiltration at the IV site, what do you need to do? Well, first off, all potassium should be mixed in the pharmacy by the pharmacist and come up to the floor pre-mixed. Okay? You should not be mixing it. You need to check the concentration and double check the concentration. If you have a question, you do not hang it. You call the pharmacist. You call the physician. Okay? Verify your orders. When you are giving it IV, you need to assess the site that you are giving or planning to give potassium through. It needs to be a large vein with a high flow volume to prevent complications. Okay? Your IV should never run faster than 5 to 10 ml equivalents per hour. When the pharmacy mixes it or when you are looking at it, you want to ensure that the concentration is no greater than 1 ml equivalent per 10 milliliters of fluid. Okay? For instance, you got a 250 milliliter bag. So, how much can your patient tolerate in that? And the answer to that would be 25 milliequivalents would be all that needs to go in a 250 cc bag, correct? Okay, so if you've got a very small bag of fluid and you've got 40 milliequivalents of potassium, you know that it's wrong. Alright? Now, like I said, it should run no faster than 5 to 10 milliequivalents per hour. You need to assess the site hourly and stop the infusion if that patient reports any pain or burning at the site. If they do, the site was probably infiltrated. You need to stop the infusion, remove that IV, and notify your physician and the rapid response team. Okay? They need to come do something with that arm because it can literally rot a big hunk of their skin off. Okay? Any patient that is on IV therapy with potassium needs to be continuously monitored with ECG. You need to monitor the patient every hour to 2 hours for the effectiveness of therapy and for potential complications. All right. The indicators of effective therapy are increased respirations. Your oxygen saturation will increase. They're going to have an effective cough again. Their hand grips and their deep tendon reflexes are going to improve. Their bowel sounds are going to start up. Their pulse is going to be palpable and regular. Their blood pressure is going to show no evidence of orthostatic drops when they get up. And your ECG should return to normal. They should have a normal ST and T wave, and the U wave should disappear. Your laboratory work is going to show the potassium is returning to a normal level between 3.5 and 5.0. You want to monitor the patient for signs and symptoms of hyperkalemia as well to make sure that you didn't overdo it, okay? And what are signs and symptoms of hyperkalemia? Well, you've got decreased heart rate, your P wave is going to be absent, your T wave is going to be tall, and your PR interval is going to be prolonged, your QRS is going to be wide. Deep tendon reflexes are going to be hyperactive, your bowel sounds are going to be hyperactive. Just the opposite of what you were seeing before, okay? And, of course, the potassium level is going to be above 5.0. Patients should be given, if you have a patient that is hypokalemic, they need to be given a potassium-sparing diuretic like a spirolactone, okay, or trimetrine or amiloride instead of your loops and your thiazides, okay? You need to monitor respiratory for increased rate and a decrease in the depth of the respirations. Assess the oxygen saturation in their ABGs for hypoxia and hypercapnia that can indicate ineffective breathing in these patients. So now let's move on to hyperkalemia. Okay? Here are some causes. You need to mark them with actual or relative. I just about forgot my word there. Okay? An elevated potassium level causes the excitable tissue to be more sensitive to a smaller amount of stimuli, and this can cause more action potentials or stronger action potentials, okay? Some may have action potentials without any stimulation whatsoever. The heart is especially sensitive to potassium, and this interferes with the electrical conduction. It can lead to your patients with heart blocks and ventricular fibrillation, okay? Severe problems can be seen when the levels are suddenly raised to between 6 and 7, or if the level is gradually raised, the patient might be able to tolerate well until that level reaches 8 or higher even, okay? So hyperkalemia is rarely seen in someone that has a normal kidney function though, okay? These patients are at risk for, the patients that are at a greater risk for this are those that are chronically ill, debilitated, and older adults, okay? So you guys get your A's and your R's placed. Now let's do some signs and symptoms for hyperkalemia. What are you going to assess for? Okay, I've got your general survey, your cardiovascular, your neuromuscular, your GI, and your laboratory here. The cardiac is the most severe problem. It manifests with bradycardia, hypertension, and ECG changes like your peak T wave, your prolonged PR. You can have a flat or an absent P wave and a wide QRS, okay, on these patients. As your level of potassium rises, the heart can even express some ectopic beats. The patient can go into a complete heart block if it's not taken care of, and even asystole or ventricular fibrillation. In muscles, what you're going to see is twitching and tingling. They can have burning and numbness in their hands and their feet and around their mouth, and these are usually in the early stages. As it worsens, the muscles are going to become weak and flat, and they'll have flaccid paralysis. The weakness can spread all the way to the respiratory muscles, and if those become affected, it can be lethal in itself for the respiratory system to be affected. Okay? In your GI, you're going to see the opposite of what we saw in the hypokalemic. You're going to have an increase in motility with diarrhea and hyperactive bowel sounds. Your stool is going to become frequent and it's going to be watery. Okay? Hyperkalemia can cause dehydration, and it's going to present in your labs as other electrolytes being elevated, like your H and H are going to be elevated. All right? If it's caused by kidney failure, you're going to see your serum creatinine and your bun are elevated. Your pH is going to be decreased, and the H and H are going to be normal to decreased, okay, in those with kidney problems. Now, what are our interventions for this? Drug therapy, patient safety, cardiac monitoring, health teaching, and dietary teaching. Can you see the thread of commonness that's running through each one of these? Okay, so you just need to get them down as to which one does what, okay? What do you do for hyperkalemia? Just get those down to specific on these levels, okay? Priority care is assessing and monitoring your cardiac complications, your patient safety and fall prevention. You want to monitor the results of therapy and health teaching. Drug therapy should be focused on restoring the normal potassium level and preventing the excretion of extra potassium. In patients that are hyperkalemic, you're going to want to stop the potassium supplement. Stop any potassium that they're receiving, either IV or PO. Okay? It might require them to have a cation exchange resin like Electrolyte to reduce the potassium level. Alright? If the level is dangerously elevated, they might even have to go for dialysis to pull it off, okay, and to remove that potassium. Potassium levels can be reduced temporarily with insulin, which is going to transport the excess into the cell. However, this is only a temporary fix, okay? The insulin increases your sodium and potassium pump. When insulin is given, it is usually given in 100 milliliters of 10 to 20% glucose with about 10 to 20 units of regular insulin added to it, okay? It is a hypertonic solution, and it needs to be given in large veins to prevent necrosis and inflammation at the infusion site, okay? You need to monitor these patients for hypoglycemia as well, because between the insulin and everything that's going on, it can cause their blood sugars to drop. You need to compare ECG tracings to ensure that dysrhythmias and other cardiac issues are caught early. You need to notify the MD and the rapid response team if the patient's heart rate falls below 60 or if they have a spike in their T-wave. Okay? Health education is key in these patients for early detection and prevention. Know your dietary considerations, and you can find those on a chart on page 167 in your med surg book, okay, for these patients. And what that does is give you the nutritional management for hyperkalemia. It tells you which foods you should avoid and which ones you can eat, okay? You need to teach them both their drug regime and their diet regime. Teach them which foods to eat and which to avoid. Okay? It's just like with the Diuretics and drug use. You need to teach them which ones to steer clear of and which ones to use in which condition they're in. Okay? Now let's go on to calcium. Calcium is needed to maintain bone strength and density. Okay? It activates enzymes. It allows skeletal and cardiac muscle contraction. It helps control nerve impulse transmission, and it allows blood clot. Okay? The function is closely related to phosphorus and magnesium. They have 2 positive charges and exist in the body as bound or free forms, either one. The bound is attached to the serum proteins, especially albumin. The free are active forms, and they are kept within a narrow range in the extracellular fluid. Calcium has a steep gradient between the extracellular and the intercellular fluids. The extracellular is high, and the intercellular is very low. Okay, it's important in maintaining your bone strength and density. Like I said, activating those enzymes, allowing skeletal and cardiac muscle contraction, controlling the nerve impulses, and in blood clotting. Absorption from food requires active vitamin D in the patient's system. When more calcium is needed, the PTH is released, which increases the calcium from the bone, in other words, bone reabsorption. It stimulates also vitamin D to increase absorption of dietary calcium. It inhibits the kidney excretion and stimulates reabsorption of calcium. Okay? When there is an excessive calcium in the plasma, PTH is inhibited and thyrocalcitonin is excreted by the thyroid. This is going to cause a decrease in your bone reabsorption. It inhibits your vitamin D, and it also increases your kidney's excretion of calcium. Calcium stabilizes the excitable membranes. It regulates depolarization and generates action potentials. It also decreases your sodium movements, slowing the rate of depolarization. Hypocalcemia is a level below 9.0. And here are your causes. Again, put an A by the actual and an R by the relative so you can distinguish the difference. Any changes in the level has a major effect on the function. Acute hypocalcemia results in a rapid onset of life-threatening manifestations. Chronic, of course, is slower. It happens over time, so the manifestations aren't as severe because the body adjusts to those gradual reductions. Okay? Hypocalcemia is caused by many chronic and acute conditions as well as surgical procedures. When your serum calcium level is low, your sodium moves across the membrane faster, increasing your episode of depolarizations. Okay, and even having some occur at random or inappropriate times. An actual loss is a reduction in total body calcium, whereas a relative loss causes total body calcium amounts to remain normal within serum, and while your total body amount remains normal, while your serum calcium levels will be lower. Okay? What are your signs and symptoms? We're going to look at nutritional history, the history as far as musculoskeletal goes, neuromuscular, your cardiovascular, GI, and your skeleton. Okay? You need to assess the patient's dairy intake and calcium supplements. One good indicator of hypocalcemia is that the patient reporting frequent charley horses in the calves or in the feet, especially when they're laying down or sleep. Most manifestations of acute hypocalcemia are caused by overstimulation of the nerves and muscles. Paresthesia in the hands and the feet often occur first. They can have tingling that affects their lips, their nose, and their ears as well. Then comes muscle twitching and then painful cramps and spasms. Okay? Now, these patients can have a trousseau sign, which is placing a blood pressure cuff around their arm. And let me see if I can tell you right fast what page number it's on. It's on page 168 in your book. As you can see, you place a blood pressure cuff up on their upper arm, just like you're going to take their blood pressure. You pump it up above at least 20 millimeters of mercury above their normal range, and maintain that for a few minutes. And as you can see here, you're going to see plantar flexion, which is indicative. That's where your hand will draw in. Oh, excuse me. And your fingers will draw in, like kind of like having muscle cramps in your hands and your fingers. And this is called a positive trousseau sign, and that is an indication of hypocalcemia. Or they can have the Chauvet's sign, which is you can listen to me, tap on the patient's face just below and in front of the ear, and they will have muscle twitching of their cheek, their mouth, and their nose on that side if they are hypokalemic. Okay? It's important for you to know the difference, and both of those are positive signs. It's important for you to know the difference and know which technique is which. All right? Cardiac changes with slower and they might have slower or slightly faster heart rate, and they're going to have a weak and thready pulse. With severe hypocalcemia, you're going to have some ECG changes, a prolonged ST interval and a prolonged QT interval. And think about it, those are your depolarization phases in the heart. Okay? GI, you're going to see increased peristaltic activity. They're going to have hyperactive bowel sounds. They're also going to have painful cramping and diarrhea. With the skeletal system, you are going to see a decrease in their bone density, and their bones will become brittle. You need to assess the patient for vertebral compression. Okay, look them over and see if they have any stoop posture or any loss of height reported. You need to also assess for any unexplained bone pain. If they tell you that their bones are really hurting and there's not a cause for that, then you need to suspect hypocalcemia. What are your interventions? You're going to have drug therapy with oral and IV replacement, nutritional therapy with a high calcium diet, environmental. What are we going to do there? I'll get into it. And then injury prevention and education. Your interventions are going to focus on restoring the calcium level and preventing any complications. Patient safety is a nursing priority during replacement until the level returns to normal. Drug therapy is directed towards replacement medications that enhance the absorption of calcium, like your vitamin D. When they're hypokalemic or calcemic, results of hyperphosphatemia. When hypocalcemia results in hyperphosphatemia, in other words, the calcium is low but the phosphorus goes up, you can give aluminum hydroxide to help increase the calcium level. Okay, so that will thereby pull down the phosphorus level. And aluminum hydroxide can also help to decrease the nerve and the muscle responses, especially in these patients that have very severe jerking and twitching. Okay? Or if it troubles the patient some. Nutrition involves providing the patient with the high calcium foods and teaching the patient about which foods to select. And again, this would be a very good time to call your dietitian. Okay? Or you can look in your book. They do have a few listed there. Of course, you know, dairy products, yogurts, cheeses, bread, sardines. Okay, that's just off of the top of my head. All right, because in hypocalcemia there's an overexcitation of the nerves. You're going to want to provide the patient with reduced stimuli. You want to keep their room quiet, limit their visitors, keep the lighting low, and use a very soft voice. You're also going to want to have stuff at bedside to maintain seizure precautions and have O2 and suction handy for these patients at bedside until their condition stabilizes. If the patient has chronic hypocalcemia state, they're going to have very brittle bones and fragile bones, so they need to be handled with extreme care. You need to make sure that all of the staff know to handle them with care, to use draw sheets, you know, that type of thing. They have a high tendency toward pathological fractures from the slightest little bump. So, like I said, use a lift sheet on them. When you're moving them around, you need to monitor their range of motion and look for any unusual bumps or depressions on bone areas in these patients. You need to educate the patient and the family on diet and safety precautions, like environmental factors like throw rugs, good lighting, hazard detection in the home. Okay? Now let's move on to hypercalcemia. Okay, here are some causes for hypercalcemia. Again, put an R by the relative ones and an A by the actual ones. Even though these effects happen first in excitable tissue, all systems of the body are affected by hypercalcemia. Okay, either the normal calcium controlling action cannot keep pace or isn't functioning properly. The excitable tissues are less sensitive to normal stimuli. It requires a larger stimulus to get a function to or produce an action potential on these patients. The tissues that are affected most are your heart, your skeletal muscle, your nerves, and your GI and smooth muscle. Okay? So what signs and symptoms are we going to watch for? Cardiac, you're going to do heart rate and blood pressure. Hematologic, you've got clotting changes that are going on, neurovascular, and then your GI. With mild hyperkalemia, you're going to see increase in heart rate and blood pressure. As it gets worse or longer it lasts, the electrical conduction is depressed and the heart rate will slow down. These you need to monitor these patients for poor tissue perfusion. Look for cyanosis and pallor. They'll have ECG changes that are going to demonstrate dysrhythmias. They're going to have a shortened QT interval on their ECG. Hematologically, you're going to need to monitor closely those blood clotting factors. The patient can have because the patient has poor blood flow, it puts them at higher risk for clot formation, especially in their legs and their pelvic regions where there is constriction. Or, you know, you sit and your pants are tight and it causes a bigger constriction. You need to monitor the calf circumference on these patients and assess their vascular condition, like their capillary refill and their temperature and their color of their extremities. Ensure perfusion is sufficient. These patients can have severe muscle weakness and decreased deep tendon reflexes without any paresthesia. They can present by being confused or lethargic. Okay. Intestinal changes are going to show a decrease in peristalsis. They'll have constipation, nausea, vomiting, anorexia, distension. Their bowel sounds are going to be hypoactive or they can be absent altogether. You need to measure an abdominal girth and monitor that as well in these patients. What are we going to do for hypercalcemia? Okay, we've got drug therapy. We're going to do some cardiac monitoring, patient safety, and patient teaching. You want to stop any IV that contains calcium or calcium supplements and vitamin D. Fluid volume replacement with normal saline to increase the sodium, which is going to increase the excretion of your calcium, okay? If they're on thiazides, they should be replaced with a loop diuretic to enhance excretion, like Lasix, okay? You'll see them on calcium chelators or calcium binders, which enhance the secretion of calcium as well. And the rest of the medications listed on your slide here can inhibit calcium reabsorption from the bone, like your bisphosphonates. Okay, you want to monitor the patient for dysrhythmias and decreased cardiac output. You need to watch that ECG for changes in the T waves and the ST intervals, which can indicate changes in your rate and your rhythm of the heart. Okay, you need to teach the patient about chronic hyperkalemia. You need to have them drink at least 2 liters of fluid each day. So, especially if they have normal kidney function, or if they have normal kidney function. You need to keep their urine well diluted because they can also develop calcium kidney stones if they're not careful. Now let's move on to phosphorus. Okay, what does phosphorus do? It helps it has levels that are higher in the intercellular fluid. It activates vitamins and minerals. It helps form energy supplies. It assists in cell growth and metabolism. Functions in acid-base balance, and it functions in calcium homeostasis. Okay, phosphorus and calcium are intertwined with a reciprocal relationship. So whichever way one level changes, the other changes in the opposite direction in the same amount. So if your phosphorus is high, your calcium is low, okay, and vice versa. Phosphorus is regulated through the PTH. If your PTH increases, your phosphorus decreases or is lost. Reduced PTH results in reabsorption of phosphorus by the kidneys, increasing the plasma levels. Okay. Hypophosphatemia is a level that is below 3 milligrams per deciliter. Here are some of the causes. You can do the A and the R with these, but you've got malnutrition, kidney failure, hyperalimentation, alcohol abuse, starvation. Okay. Body functions are not important for rapid changes. It occurs more with chronic hypophosphatemia. Okay. Most is related to decreased energy metabolism and fluid and electrolyte imbalances. The antacids used includes both aluminum hydroxide based and magnesium based antacids. So when you see on this slide where it says antacid use, it's talking about hydroxides and magnesium based both. Okay. Signs and symptoms of hyperphosphatemia. Excuse me. You're going to look for cardiac changes, musculoskeletal changes, hematologic changes, and central nervous system changes. Cardiac is going to demonstrate weak contractility. They're going to have decreased stroke volume, and a decreased cardiac output. Peripheral pulses are going to be slow and difficult to find. With prolonged hyperphosphatemia, you're going to see a progression in the cardiac muscle damage, but this damage is also reversible when you correct the hyperphosphatemia, okay? You're going to see weak skeletal muscles that can progress to rhabdomyolysis, okay? with the muscle weakness, be aware of the respiratory effort, because the muscle weakness can lead to respiratory failure. So anytime you hear muscle weakness, you also think about your respirations, okay? With chronic hypophosphatemia, your bone density is decreased, which can lead to more fractures. In the central nervous system, there's going to be no apparent changes until the condition is very severe. Then the patient is going to present with irritability that can progress to seizure activity, and that can be followed by comas as well. Okay? Alright, now let's move on to interventions for hypophosphatemia. In this, you're going to stop the antacids, the osmotic diuretics, and any calcium supplements in the hypophosphatemia. They might have IV phosphorus given if the serum level falls below 1 milligram per deciliter and the patient has serious manifestations. It should be given slowly because the problems caused by hyperphosphatemia are equally as serious as hypo. Okay. Nutritional therapy involves increasing the intake of phosphorus-rich foods and decreasing your calcium in your diet. Remember, because they have a reciprocal effect on each other. Teach the patient to eat a diet high in phosphorus and low in calcium. It might be tricky because most foods that are high in phosphorus are also rich in calcium, like milk, ice cream, cheese, pudding, cereal, bread. Other foods that are high in phosphorus would be corn, mushrooms, dried fruit and peas, asparagus, dried beans and peas, believe it or not, pancakes, waffles, sardines, and peanut butter. All I can say is, like I've told you before, collaborate, call that dietitian for help, okay? For hyperphosphatemia, you're going to see a phosphorus level that is greater than 4.5, and the causes are your kidney disease, tumor lysis, high phosphorus intake, and hypoparathyroidism. The problem with hyperphosphatemia centers on the results decreasing in calcium that we discussed earlier, resulting in an increase in membrane excitability that can cause life-threatening side effects. So the management is focused towards managing your hypocalcemia that these patients are experiencing, okay? Now we're going to move on to your magnesium. And I know that Miss Enlos has touched on some of this with you as far as in the OB stuff goes. If she hasn't, she will soon. Okay? Mag citrate is your number one. Okay? What does magnesium do? It helps, it's stored in bones and cartilage. It helps with skeletal muscle contraction, increasing your nerve impulse contraction, carbohydrate metabolism, generation of energy stores, vitamin activation, blood coagulation, and cell growth. Okay? Regulation is achieved through the kidneys and the GI tract. Regulating forces aren't understood. In other words, we don't know what triggers it. Okay? When the levels are low, the kidneys stop excretion of magnesium, and it is rapidly absorbed after ingestion. These effects are caused by increased membrane excitability, which can cause the cells to depolarize spontaneously, especially in the nerve cells. Okay? Like I said, the activation is not well understood. Okay, signs and symptoms of hypomagnesemia to assess for is your neuromuscular changes, increased nerve impulses, and GI changes. Neuromuscular changes are caused by increased excitability and the imbalance of serum calcium and potassium. So the cell membranes can depolarize spontaneously. Magnesium inhibits the impulse transmission normally, so decreased magnesium levels are going to lead to increased impulse transmission from one nerve to another nerve or from nerve to a muscle. The patient will exhibit hyperactive deep tendon reflexes, numbness and tingling, and painful muscle contractions. They will have a positive Trousseau's and Shabach's signs, which lead to which are just like hypocalcemia. Okay, GI changes result from decreased smooth muscle contraction, which reduce your motility. These patients are going to exhibit anorexia, nausea, constipation, abdominal distension, and they are at high risk for a paralytic ileus, especially if that magnesium level is severely low. Okay? Interventions for hypomagnesemia. Okay, you're going to correct the imbalance. I'm sorry, I didn't turn my slide. Correct the imbalance, manage causative factors, restore normal magnesium and calcium levels. Drug therapies like mag sulfate, calcium supplements may be needed as well, and you need to monitor that lab work. You need to discontinue any loop or osmotic diuretics that these patients are getting, aminoglycoside antibiotics, and any drugs with phosphorus. Okay? Magnesium sulfate is given for severe cases. You need to assess the deep tendon reflexes at least every hour in these patients, especially if they're receiving IV mag, to monitor the effectiveness and to prevent them from ending up with hypermagnesemia. Okay? Some of the causes of a hypermagnesemia would be a magnesium level, that's the magnesium level of greater than 2.1, and the causes can be antacids and laxative use or IV magnesium replacement or kidney disease. Okay? Like I said before, magnesium is a membrane stabilizer. Most manifestations of hypermagnesemia occur because of a reduced membrane excitability. Most are not noted until the serum level is in excess of 4 milliequivalents per liter. Okay? So what are our signs and symptoms that we're going to assess for? Cardiac changes, your central nervous system changes, neuromuscular changes. Okay? The patient may exhibit bradycardia, peripheral vascular dilatation, and hypotension. When the magnesium level gets severely high, you're going to see ECG changes that like prolonged PR with a wide QRS complex. If bradycardia is severe, they can go into cardiac arrest. Patients with severe hypermagnesemia are in grave danger of cardiac arrest. A depressed nerve impulse present with drowsiness and lethargy can be seen in the central nervous system. The patient can slip into a coma if the condition is prolonged or if it is severe. The patient will have decreased or absent deep tendon reflexes, and voluntary muscle contractions will become progressively weaker and finally stop. The muscle weakness is present. If muscle weakness is present, excuse me, you need to assess again that respiratory status because the respiratory insufficiency can lead to failure and to death also. Okay? Interventions for hypermagnesemia, you want to focus on the reduction of magnesium level, correcting any underlying problems, IV magnesium-free fluids with good kidney function, and drug therapy, such as loop diuretics and calcium supplements. You want to stop all oral and parenteral magnesium. Magnesium-free fluids will dilute and flush out the excess magnesium. Loop diuretics are going to help to flush out the excess. And you can give them calcium supplements, which will reverse cardiac effects of this condition. Okay? Now, let's talk about I believe our final one. Yes, it is. How about that? And that is chloride. The normal value is 98 to 106 milliequivalents per liter. What does chloride do? It works with sodium to maintain your extracellular fluid osmotic pressure. It is also important in the formation of hydrochloric acid in the stomach. What causes complications with this is a chloride shift. Imbalances usually the result of other imbalances. In other words, because your sodium's down, your chloride. Okay. Excessive vomiting or prolonged gastric suctioning. Chloride shift results when your bicarb and your chloride change places when the bicarb is moving out of the cells, and the chloride will then move into the cells. So there is no real net body loss. Imbalances are usually corrected by interventions for correcting other imbalances, and that is basically my lecture to you on fluid and electrolytes. Now, I encourage you to read over these chapters real well. Also, you have my article on fluids that I've told you about, and it has a great chart on, well, it has some good evidence-based practice on the controversy of fluid resuscitation, but it also has a good chart in it on crystalloids and colloids and what their action or use is, and nursing considerations for each one of these. Okay, you also have a couple of chapters in your lab book which just basically reiterates what I have in these two, but you might want to read through those chapters right quickly or skim through them. You don't actually have to read them. Okay, if you have any questions, please feel free to come see me, send me emails, whatever you need to do. Remember, I am here for you, and I thank you for your time. And I'll see you on the weekends. Okay, bye.